Good afternoon, and welcome to the SAMHSA Gain Center webinar on Integrated Mental Health and Physical Health Mobile Crisis Response. This is the third of our Crisis Response Virtual Learning Community webinars. I'm Dan Abreu, and I will be your moderator for this session. And our disclaimer: the views, opinions, and content expressed in this presentation do not necessarily reflect the views, opinions, or policies of the Substance Abuse and Mental Health Services Administration or the U.S. Department of Health and Human Services. So a couple of housekeeping items. So there's a chat box at the bottom corner of your screen, and throughout the presentation, feel free to enter questions there as you wish. At the end of the presentation, we will try to address as many of those questions as time permits. Also, this webinar is being recorded, so we ask that you mute your phones, and please do not put your phones on hold. The Gain Center has arranged for live captioning today to enhance accessibility. To view live captioning, select the Accept button in the multimedia pod located in the lower right-hand corner of your WebEx screen. You can change the color contrast of the live caption pod to suit your needs. We recommend selecting a high contrast style for best visibility. In addition, following this webinar, we will host a discussion group to allow more in-depth discussion with our presenters, Annie Burwell and Kate Gillespie. Please note, participation in the discussion group will require you to terminate your phone and computer connections, and a new web link and phone number will be provided at the conclusion of this webinar to join the discussion group. Before I introduce our presenters, I'd like to provide some context. Last year, the Gain Center added Intercept 0 as a sixth intercept to the sequential intercept model to highlight the civil, non-criminal role of police in responding to individuals experiencing a mental health crisis, and an expanding role often fostered by police CIT programs in prevention and post-crisis follow-up. Intercept 0 also highlights non-law enforcement responses and the role of fire and emergency medical services in responding to individuals in behavioral health crisis, the importance of their partnerships in crisis response and diversion, and the increased specialization of fire and EMS response. This webinar is also timely as communities seek to bolster their crisis response strategies to reduce the demands on law enforcement to respond to non-criminal crisis events. And this is an emerging model also. In 2018, National Association of Emergency Medical Technicians updated their 2015 survey of the nation's currently operated mobile integrated healthcare and community paramedicine teams. The survey included 129 agencies across 34 states, and these programs share the following characteristics. They send EMTs, paramedics, or community paramedics into the homes of patients to help with chronic disease management and education or post-hospital discharge follow-up to prevent hospital admissions or readmissions. They navigate patients to destinations such as primary care, urgent care, mental health, or substance use treatment centers instead of emergency departments. They deploy telemedicine to connect patients in their homes with caregivers, and they provide telephone advice or other assistance to non-urgent 911 callers instead of sending an ambulance crew. These programs are not necessarily restricted to behavioral health responses and often include responding to medical conditions such as asthma or other respiratory conditions or diabetes, though some of the programs do specialize in behavioral health response. This is an emerging field, and the survey found that these models are relatively new, with only 62% in operation 2 years or longer, which is up from 20% in the 2015 survey, suggesting that once implemented, these programs are sustainable and valued in their communities. Survey also found that, like CIT, partnership development is essential. These programs collectively reduce hospital admissions, target frequent service users, provide chronic disease management, and an alternative to transport to the ER. Full disclosure, though, these programs often face both legal and regulatory barriers and funding barriers during implementation. Our presenters will address these issues. So at this point, I'd like to introduce our first presenter, Annie Burwell. She leads the nationally recognized Williamson County Mobile Outreach Team, a division of Williamson County EMS, Texas. She's been working in the behavioral health field for over 30 years and has significant experience in crisis response, suicidality, trauma intervention, and substance use disorders, and is a certified hostage negotiator. She's a clinical instructor at the Texas A&M Health Science Center, Department of Psychiatry and Behavioral Health, and serves on many community boards, including the Williamson County Commissioners Court Behavioral Health Task Force. She's a licensed, Kate Gillespie, who will be our second presenter, is a licensed clinical social worker who has worked for the Whitebird Clinic since 2010 as a crisis worker, as well as a clinical supervisor and an administrator. She has worked in the mental health field for nearly 2 decades, including work in local emergency departments, a state psychiatric hospital, and a mobile crisis unit. She has a private practice as a therapist and enjoys non-traditional therapeutic environments like wilderness therapy. And now, Annie Burwell.
Good afternoon. First of all, thank you to SAMHSA and to the Gaines Center for the opportunity to meet virtually with you all today. It's an honor to present alongside CAHOOTS, which is a program that we researched over a decade ago. As Dan said, I serve as the director of the Mobile Outreach Team for Williamson County, and our 911-based program is a division of our EMS department. Our team is composed of 7 mental health specialists and 3 paramedics and some administrative support, and we respond to approximately 3,000 calls for service each year. All right, let me see if I can advance the slides. There we go. All right, so I want to give you a little bit of information about Williamson County. Our program is a countywide program, and we have a geographic area of about 1,200 square miles. We don't have a dominant city in our county. Instead, we have a mix of small and medium-sized cities and rural areas. And this means that we respond to different law enforcement jurisdictions, all with various cultures and procedures on a day-to-day basis. We have, I believe, 39 jurisdictions. About 15 of those we work with on a daily basis. We're in a rapidly growing area near Austin, and our county is bisected by I-35. So about 200,000 people travel on highways through our county of about 610,000 people every day, which leads to a lot of calls. We do not have a shelter nor a countywide transportation system, which, as you might guess, presents us with some challenges. As you can see, our team has 3 core functions, and as you can imagine, all have been complicated by COVID. We have a separate community health paramedicine program in our EMS department, and we work closely with them. So I'm not going to spend much of our time today talking about chronic disease management or high utilizer reduction, but we have a great department that can give you some more information on that, and we do work calls together. Most of our clinicians' time is spent responding to 911 calls for persons who are suicidal or homicidal or experiencing symptoms of psychosis. And we also provide overdose prevention and response services and system support. In the past few months, our call volume has doubled, related to COVID and the stress that's caused. We started as a pilot program in 2004 when our county judge was determined to decrease arrests, ambulance and emergency department use, and state hospital admissions. And you can see our first response vehicle that is not a maintenance truck, that is an emergency response vehicle. And Frank, shown there in the picture, was always getting asked to deal with water meters. So if you're just starting a program, take heart. You can grow up too. But even though our start was modest, we demonstrated immediate success by reducing arrests and admissions, and we soon graduated to fancy Malibus. Our state hospital bed rates dropped from 160% of overuse to 60%, and for every $3 that the county put in, every dollar that the county put into the program, we saved $3. We transitioned from a pilot program to a county department in 2006. These days we run 2 types of units, one being what we just call an MOT unit, which is a mental health specialist, 1 or 2 mental health specialists in one vehicle. And we run M&M units, which that includes a medic and a mental health specialist assigned to the same call. And of course, these days we're responding in separate vehicles for social distancing. So I want to spend just a couple minutes talking about the evolution of our program. Initially, we were co-located and co-responded with the Sheriff's Office Crisis Intervention Team. And that was great. It's hard to start a program and to grow a program, and needs and budgets change. We weren't employed by the Sheriff's Office, but we responded and collaborated and cooperated with them very closely. And this was great for us to learn about law enforcement culture and how equipment works and dispatching and all those processes and procedures. But both units, meaning CIT and MOT, found that we really could be more efficient if we responded in separate vehicles by essentially backing each other up. That way, if a deputy needed to respond to something like a burglary, we weren't stuck out with that, and the deputy didn't have to sit through some of our longer crisis counseling or follow-up sessions with us. So that's how we started. These days, we're a division of EMS, and I think this works really well. We're part of a well-respected, medically sophisticated system, and it feels like a good home for us where we can be really helpful to the citizens in our county. So if you're considering a co-response model, I'd be happy to answer questions about our experience and some of the trials and tribulations and victories that we've had. Some people lately have asked us a lot about hiring, how we choose the professionals for our team. And what we look for when we're hiring a co-responder is, first of all, a capacity for big love. It's just the best way I can think of to describe it. Someone with a big heart who loves their neighbor in crisis and who loves the work. Someone who has really good judgment and common sense, can think on their feet, who has street smarts, has grace under pressure, and loads of patience, and they can tolerate a wide range of behaviors and respond with compassion. It's also a bonus if they have lived experience with behavioral health issues, either themselves or a family member. And of course, we always want, experienced, licensed social workers or licensed professional counselors and licensed paramedics. But I'm also willing to hire, say, a very skilled child protective services worker or a probation officer, or even someone with a master's in public health. So that's kind of who we look for when we're hiring. We do an experiential interview process with testing and scenarios to let that cream sort of come to the top when we make our hiring decisions. Okay, let's get into some nuts and bolts about what works well for us. We have what we call a flexible dispatch model. So for some behavioral health calls, those calls can be managed. And when I say call, I mean a response, a field response. Some of those calls can be managed by a single clinician, while other calls need, a fire truck, EMS, law enforcement, animal control, everything in the helicopter, and MOT. But often we don't need everything with a light and siren to go to a behavioral health crisis call. We want to send the right resource at the right time. We don't want to send a fire truck to a sad person. And this is best, of course, for the patient and for the taxpayer. So let me kind of walk you through how this works in practice. So imagine a 911 dispatch center, and someone calls in and says, my brother has bipolar disorder, and he's out of his medication, and he's upset, and I don't know what to do. So our call taker dispatcher would ask that person some more questions, make sure that there's not an active disturbance on the scene. They'll check their computer-aided dispatch system for history of violence, and then dispatch us out via radio to that call. When we get on scene, we're going to assess, find out what's going on, provide the appropriate care, make a plan, get them hooked up with resources, transport if that's needed, and then follow up. So we will follow up until the situation is stable, and we can talk a little bit more about that in a minute. If the call comes into the 911 center as a medical emergency, so for instance, it comes in as difficulty breathing, our 911 call taker is going to dispatch EMS. And so EMS is going to arrive on scene. Then they determine, this isn't a medical emergency, this is a panic attack. And so they'll hop on their radio and request an MOT unit. They may or may not stay on scene depending on the situation. And once we get on scene, we'll do the same sort of intervention that we would do as I outlined on the other call, and then we'll put them back into service. So we always want to put our fire, EMS, and law enforcement partners back into service as soon as possible. Now, if the call comes out on the law enforcement side of the house, let's say someone calls in and says, there's someone trespassing, or it looks like there's something going on with public intoxication. Law enforcement's going to go out first, and then they can request MOT, and we will be en route. And again, we're going to try and turn that other first responder back into service as quickly as possible. Now, this can work backwards. So we may go out on a call and make a determination that this person needs medical care, that there is actually a medical issue that needs to be addressed and it's emergent, and we're going to call for EMS. Or if our situation becomes unstable, or we determine someone on scene is the victim of a crime, something like that, then we're going to request law enforcement. So that's how our dispatching works. Of course, we always want everybody to be safe. We need everybody to be safe. So we do our best to collect some background information while we're en route to the call. And that may mean we're going to look in our charting system and see if we have previous history with the individual. Our dispatcher call takers, they're also going to take a look around in CAD and see if there's something that we need to know about. And then lately, of course, we're being alerted if we need to use extra PPE. So we get background. We like to call someone on scene and get some more information about what's going on if that's possible. We may also do some a telemed or a telesession on our way if that's appropriate. But our staff know that if things get out of control or get escalated, they can always back off, back out, and call for backup. And in over 35,000 calls, we have not had a serious injury or event with a consumer client or with our staff. And actually, probably the most dangerous thing that we do is driving. Driving and fatigue would be our biggest safety factors. Okay, so once we're on scene, we're going to assess the situation. We're going to rule out any medical concerns or any medical issues that are contributing or causing the behavior that started this 911 call. If we're in an M&M unit, we're going to do a pretty thorough medical assessment with our client, get a good medical history. And again, kind of going back to our flexible dispatch model and sending other units back and seeing I just want to acknowledge that these calls take a long time. And so for us to make the best decision with a consumer, it's good for us to turn those units back. They don't need to stand around if the situation is safe for us to do a thorough assessment and gather information. So we assess what's going on. We link the person with the most appropriate resource. Now that may be psychiatric care, that may be intensive outpatient, that might be substance use treatment, that might be that the person just needs groceries or a tent or a link to the local mental health authority clinic. So we try to match the resource with the need, and then about 80% of the time we don't need to either take the person off scene or move towards inpatient care. And, because we always want to go with the most least restrictive plan, right? We don't want to hospitalize someone unnecessarily. We're going to divert when appropriate. And what that means for us is that if we're out with law enforcement or if law enforcement has requested us and there's a decision about should this person go to jail or should they receive behavioral health care, of course, we're going to advocate for that care and divert them from jail. In our county, we only count something as a diversion if we have an arrestable offense and an officer is on scene. And then we're going to provide follow-up if needed. Most of our calls are one and done. But if there's like a waiting list for services or no beds available or something like that, we will keep going out either face-to-face or phone contact until the situation is stabilized. So, again, we're looking at medical issues to make sure that they're not getting in the way of psychiatric care or causing some problems that we need to go that route first. And then, what other factors are impacting, or what other risk factors do we have here? We're looking for risk factors about violence, suicidal behavior, things like that. And then what are the barriers to accessing care? Is it transportation? Is it language? Is it insurance status? Things like that. To make our program run really well, to add to sort of the brains and the hearts of our clinicians, we have some extra tools. My favorite tool that we have is flex funding. Each year we're given about $50,000 in flex funds, and that there's really nothing that will scare an auditor, a county auditor, more than giving a bunch of social workers credit cards. But every year we've passed our audits, all 21 of them, and we have permission to use this money for persons who are in crisis and or have symptoms of mental illness And if we purchase something, we can help resolve the crisis. Now, most of the time, that's medication, psychiatric care, counseling, but it can also be things like gas for their car to get to appointments. Maybe they're unhoused and they need food. Maybe they need medical supplies, insulin, wound care, things like that. We are the payer of last resort, so generally this is a one-time payment. So we're not going to make a rent payment or something like that each month. This is an emergency payment, and then we're going to help that person access resources in the community so that they have ongoing care and so they don't come back in front of the 911 system. We also have access to telepsychiatry, which is great because we have a shortage of psychiatrists in our area. And most of the psychiatrists in our area don't take insurance, so we can purchase psychiatric sessions or provide telepsychiatry on an emergency basis in the field with our iPads from our CAHOOTS. And those psychiatrists can consult with us, do medication refills for us, get a new medication if needed, and this can be kind of expensive. This costs us about $400 every time we do it, and maybe another chunk of flex funding for medication. But that is still a great use of taxpayer funds if we have kept that person out of an emergency department or out of an inpatient facility. We also carry a breathalyzer. This is not to get anybody in trouble, but if you've been on these types of calls, you know that a lot of times people say, oh, I've just had 2 beers. And so we want to make sure how much that person has had to drink before we take them to a psychiatric facility or to determine if maybe we need to go to an emergency department. And then we are also able, through our data waived physician, to provide fast track to medication-assisted treatment. And so we don't have time to get into the details of our opioid overdose response program, but just to give you a quick overview, we respond to that overdose either during the time of the call or shortly thereafter, provide naloxone kits, access to opioid agonist therapies, and peer recovery coaching. All right, so we talked a little bit about field-based medical clearance. Basically what we're looking for, a good candidate for field-based medical clearance. And for us, we do a lot of that because we have freestanding psychiatric hospitals in our county. Our hospitals are not associated with medical hospitals. So if we can transport a patient directly to a psychiatric facility and skip an emergency department and make sure that the consumer and the psychiatric hospital feel safe because we've done a medical exam, that works out for everyone. Of course, this can't happen if the person requires sedation or they're combative and things like that, but generally a psychiatric hospital will accept our clearance. So good candidates for medical clearance, again, are those who don't have any, major wounds. They haven't been sedated. We know exactly what they've taken. Maybe they have something that needs a few Band-Aids, but they don't need to be stitched. Maybe they're taking medication for a chronic condition, but they don't need emergency care for that. All right, some challenges that we've had, and I can address some of these in question and answer later on if you want to ask some more questions. But we all know that budgets and grants are difficult and time-consuming. We need to live within our budget, and we need to do our grant reporting. But as you guys know, that does take time away from our clinical work. We were struggling with double charting, so a medical chart and a behavioral health chart. We finally, thanks to one of our clinicians, been able to merge our charts. So we're overcoming that sort of as we speak. And then call volume and burnout, which is sort of typical challenges for people in the 911 field. Some of the great work that we've done is that we've had 35,000 calls with really no serious incidents or deaths. Our opioid overdose response program is working well. We have a lot of diversion savings for the taxpayers, and we have good relationships with the partners in our county. We collect a lot of data. Our commissioners are very interested in which law enforcement departments we're working with, call volume, response times, how the call comes through our CAD system, how many jail diversions we do, how many hospitalizations we had, things like that. Those are produced each month. And of course, then we have grants that we also provide different metrics to. All right, so if you want a little bit more information about our program, here's some news stories, and then that you can follow those links to. You can also do a Google search for Mobile Outreach Austin American Statesman and see what we look like in our PPE. And at this point, I think I'm getting ready to turn it over to Kate. Again, I really appreciate you guys listening today, and please don't hesitate to contact me if you have any questions that I can help you with.
Thanks, Danny. That was great. This is Kate Gillespie in Eugene, Oregon, and I'm very happy to be here, honored to have a seat here and be part of this conversation. As you all can imagine, CAHOOTS has been getting a great deal of inquiry about our model in recent socio changes in our country. So I'll go ahead and give you guys a bit of a background. So Whitebird Clinic was formed in 1969. It started as a volunteer-run crisis center for marginalized folks, kind of during the development of the counterculture. Many of the people during that time that were accessing our crisis center had fears, often for good reasons, of going and accessing conventional resources like the hospital or police or fire, EMS at the time. So Whitebird Clinic started as a group of volunteers from the University of Oregon, both students and professors, that created a 24-hour-a-day crisis walk-in center for folks to come in. It was just a small house in the Eugene area, not far from the university. And we opened our doors then and haven't closed our doors for our crisis center a day since then. Right now, we're running a 24-hour crisis line in the midst of COVID. We are an FQHC, so a federally qualified health center. Our priority is to serve people who are underserved, underinsured, disabled, or unhoused. And out of the volunteer-run crisis center that started in 1969, we slowly began getting funding and slowly started hiring paid staff. Today, our FQHC has a crisis walk-in center, ongoing counseling, outpatient drug and alcohol treatment, CAHOOTS, our mobile crisis unit, NEST, which is our navigation empowerment service team, so we do kind of targeted case management there. We have what's called our Front Rooms program, and this is kind of day access services where people can use a toilet or get mail and messaging. We also have a medical clinic, and at the medical clinic we also have a medical assisted treatment and then we have a dental clinic. So one of our largest fundraisers is a program called Rock Medicine, and at Rock Medicine we have a pool of about 400 volunteers, doctors, nurses, paramedics, who come and volunteer at events like the Oregon Country Fair. Back in our roots in the 70s and 80s, we were at a lot of Grateful Dead shows in the area, and that's kind of where we started our crisis worker medic model. So in 1989, when the Eugene Police Department was noticing that Whitebird Clinic was sometimes sending some of their crisis workers from the crisis clinic out to people who maybe had phoned in and were having a hard time, we would respond in a sedan at those scenes, and sometimes police would show up as well because the person was so escalated. And they said, hey, why don't we work together and create a crisis unit here in Eugene? So this is way back in 1989. You can see here in this slide, there's some of our first medics in what was our first CAHOOTS van. And so that started on July 4th, 31 years ago. So Whitebird Clinic and CAHOOTS is an organization that really believes in being client-centered. One of the folks in our county who does trauma-informed training says that they believe CAHOOTS and Whitebird were providing trauma-informed care before it was named trauma-informed care and became a standard service model for all of our mental health folks across the country. We really believe in letting people be the expert in their own life and treating people with unconditional positive regard, free of judgment and discrimination. We believe in harm reduction, and we work closely with HIV Alliance here in Eugene and Springfield, and we really believe in, helping people access the healthiest options possible. And sometimes that looks like sending people to do clean needle exchanges, and other times harm reduction for us looks like maybe giving somebody a bottle of water who is really disoriented and having a hard time, but maybe not meeting the criteria for hospitalization, of just getting people a chance to have a human connection and dignity in their difficult situation. So here is a list of some of the services that we provide on CAHOOTS, and this is definitely services that we do provide, but not limited to. We definitely do crisis counseling, and sometimes that looks like somebody just having a bad day, and other times it looks like doing a suicide risk assessment for somebody that maybe they just lost their job and they feel like that's their only option. So trying to determine the risk of suicidal ideation. Other times we're doing conflict resolution and family mediation. Sometimes we will respond to a family where maybe their 15-year-old is being an adolescent and pushing the boundaries that the parents have set, and parents are kind of at their wits' end and not sure where to go. And so we'll come in and talk, and just having that third party kind of non-biased person there can help mediate things. But we can also transport to different services. In Lane County, we have a shelter where youth can go, whether they're runaway unhoused youth or youth that are just needing a timeout from home. We do a significant amount of grief and loss counseling, and sometimes that looks like maybe responding with PD to the scene of a completed suicide and working with a family that is in shock and needing support right in that intense, tragic moment. And other times that looks like maybe somebody lost a parent or a loved one 5 years ago and it's the anniversary of the death and they're just having a hard time and they need somebody to talk to. So we'll come chat with them. We do welfare checks. And welfare checks can mean a lot of different things for us. Sometimes it's a family member out of the area calling grandma and she's not answering the phone and they don't know why, so they need somebody to go have eyes on her. And other times it's somebody that's down on the street in the city and is maybe unconscious and not responding, or the person doesn't feel comfortable, seeing if they can rouse the person. So we will respond to those types of calls. Our substance use intervention can look like somebody, again, on the street needing intervention for intoxication, and other times it's somebody that maybe has some time clean and sober and needs a little support with that in that moment. A lot of what our substance use intervention looks like, maybe a mother of a 40-year-old person who is been having chronic alcoholism. She thinks that person needs to change. We respond. The person who we were called for tells us they don't want our service, and then we're doing a lot of like community education, discussing what boundaries and resources the person can access in managing their family member who's having a substance use issue. We definitely do a fair share of shelter crisis or housing crises. We have one shelter here in Lane County, and it has about, at this point with COVID, it has a little less than 200 beds. It was up in the like 350 range, but they've had to decrease the amount of people they can serve during COVID. And we do know that we, in our last point in time count, we had 4,000 people come up on that for our point in time count, but we estimate that could potentially be double, it could be double that number. So 200 beds is pretty minimal for our need in our county. Because we always have a crisis worker and a medic on our van, we provide first aid and non-emergent medical care. And we do a significant amount of wound care in our community for folks that maybe aren't able to get in to get wound care, or they're out on the streets and they're not able to maintain clean bandages and supplies for that. So we'll come out and do those types of interventions in the field. A big part of what CAHOOTS does is client advocacy. CAHOOTS teams and Whitebird Clinic staff facilitate resource connection and individual patient advocacy. We support marginalized communities by providing a voice and avenues of communication for various collaborative groups. These groups include representatives from local law enforcement, municipal government, hospital systems, service providers, public health, and our county behavioral health. We do respond to intimate partner violence and family disputes. However, the intimate partner violence is oftentimes responded to by PD before we go into the situation. So as I mentioned before, we always have a crisis worker on our van. And so that person generally has at least 3 years of experience working in the behavioral health field, oftentimes in environments that provide crisis intervention and de-escalation. So people come from backgrounds of other programs at our clinic, or our youth shelter is often a referral source for our staff. We don't require a bachelor's degree, but most of our folks meet the requirements for what we call a qualified mental health associate here in Lane County. So they are they have the background and knowledge to step into the job and into our training process swiftly. So our medics are licensed in Oregon as EMT basics, paramedics, or registered nurses. So they deliver their services in non-traditional environments, so different from our county EMS services. They can clear somebody in the field for medical things. Oftentimes, we're sussing things out. We're able to provide blood pressure, temperature, kind of just basic vital checks for people. We are able to check blood sugar, and we can begin emergency procedures if needed. So we will call for medics if somebody is unconscious and unresponsive. We carry oxygen on our vans, but we are not emergency services. We are actually considered a mobile medical clinic is what we are. And so we can't transport with oxygen on, but we can start it in the field if we maybe come across somebody who has OD'd and we've administered naloxone. We'll pass to our EMS partners. But again, a lot of our medics are, assessing people who are maybe having cold-like symptoms, and we determine that maybe they don't need to go to the hospital. Maybe they need to go to urgent care. So that's, again, part of that community education piece. So taking the opportunity to educate someone that maybe hasn't in their lifetime had a primary care doctor and saying, we're seeing you and you have high blood pressure, and this seems to be an ongoing thing that we're seeing. So let's get you wrapped into Whitebird Medical Clinic where you can see a doctor and get an ongoing relationship there. So our funding, again, we've been under the Eugene Police Department's budget since 1989, and that funding has been consistent over the past 31 years. In 2014, we got a state grant passed down to our county, and we were able to expand our services fully from the Eugene area into Springfield, which is our sister city. So the metropolitan area of Lane County, Eugene and Springfield, has about 270,000 residents of our county that has about 500,000 residents total. So we have this slide says that we have 55 hours of service a day, and we've actually expanded within the last few months to 60 hours of service hours a day. So we have 24-hour coverage in both Eugene and Springfield. We have one van that just stays over in Springfield consistently for that 24 hours a day. And then we have a van in Eugene 24 hours a day, and a second van that comes on at 10 o'clock in the morning and runs until 10 o'clock at night. So we have a double coverage during those high volume hours. And we're operating just below $2 million annually for those 60 service hours daily. So we are dispatched through non-emergency dispatchers here in Lane County. In Eugene, we have a phone number that dials into our county dispatch and is received by our non-emergency police call takers. And our call volume is triaged by these call takers, and they prioritize sending us to suicide prevention calls first. Second is police assist, and third is EMS fire assist. And we oftentimes have many calls holding. Our service has demonstrated that we can really help alleviate the call volume for law enforcement because we're in the police budget. We are kept within their statistics. And at this point in Eugene, we're responding to about 20% of the patrol calls in the city. We respond to about 80% of our calls without any law enforcement or EMS, and the other 20% we do respond with law enforcement. Sometimes that is PD going in on maybe a suicidal person who has expressed that they have a firearm, and so patrol goes in and secures the scene, and then we'll call us in as we're staged in the area. Other times, we may go in with police if there's no mention of danger to our workers. So worker safety is a thing we get asked about often. And, you know, I have worked with the CAHOOTS team for about 10 years, and I've even worked at almost a full-time capacity on the van and have very few instances where I've felt really unsafe during my job. And this has to do with a pretty strong emphasis on training about scene awareness. So just that's one of the big cornerstones of our training process. Our two-worker model is really important to our safety, so we maintain line of sight contact with each other whenever we're out on calls, so we don't leave each other's side, and we can help have scene awareness. When my medic is working with somebody and doing an assessment, then I'm often, you know, making sure that that situation's going okay, as well as seeing if anybody is incoming into the scene. So we're hyper vigilant in our service delivery. We also rely heavily on our police radio being on our hip, as we say. We're able to call for lights and sirens, police coverage with the click of a button. And because we've been working with our law enforcement partners for so long, they really are protective of us. They kind of see us as their little brothers and sisters out there on the streets. We definitely do driver training to make sure that everybody is educated on defensive driving, because that is definitely a point of risk in our jobs. We rely on our uniforms, which consists of a sweatshirt or a t-shirt with our logo on it, and then some people do wear duty pants, but a lot of people just wear blue jeans. And that's to make sure that people know who we are, but also not look too much like law enforcement. So having that kind of differentiation from law enforcement. And then we have a strong clinical debrief component so that people are able to process situations that they've been in and talk about how they can improve their work and their interventions. And then definitely we rely on our intuition, because, you know, that gut instinct is really valuable in keeping yourself safe. So again, we're not responding to a large portion of our calls with other agencies. We're able to free them up to take care of situations that require law enforcement or actual emergent medical intervention. We are responding to about 25,000 calls annually at this point. And we very rarely have to call for what we call Code 1 or Code 3 cover, where we need law enforcement to back us up because of perceived danger. So just 1% of our call volume requires that kind of support from our partner agencies. Things that we don't do. We don't restrain people or take people against their will. There are times where, because we're mandatory reporters, if somebody, maybe we respond because somebody's been thinking about overdosing on all of their medications to, with the intention of completing suicide, then if we can't get them to contract for safety or agree to come with us to the hospital willingly, we will have to call in law enforcement at that point to have them put on a police hold and brought into our emergency department. We don't provide transportation to people's private residence for safety and liability reasons. But otherwise, we do transport people to staffed services. So that can be the hospital, but it can also be to the crisis center. It can be to the county behavioral health. It can be to our sobering station, which in fact has been closed down due to COVID, but we're hoping will reopen soon. And then we don't judge people. Our goal is not to fix people, but allowing people to be the expert in their own lives to have the best intervention possible. Can I interrupt you for a second, Kate? Sure.
Yeah. So we're moving to the top of the hour. So we have, we're going to shift over to our discussion group in a few minutes. So I'm going to give you maybe another minute or so if you wanted to just summarize move to another slide or two. Otherwise, we're going to have to move on to the next section. I apologize for the time crunch here.
No worries. Okay. So a big focus of the work that we're doing is emergency room diversions as well as jail diversion. We work very closely with our community partners. We believe that mobile crisis intervention is really only as strong as your community partners and the community resources that you can lean on for resource referral. Some creative solutions that we've had for people in housing crisis is these what we call Conestoga huts. So it's a small flatbed trailer with a cattle panel kind of bent over that with a closing door on one end and a wall with a window on the other end. So it provides a little bit of safety with a locked door, but it's a fairly inexpensive alternative to shelters. We do have what's called our community outreach team, and this is a CAHOOTS team that provides 10 hours a week of intensive case management working with our downtown patrol officers. So it's in a very targeted area of our city. Some things that we provide to our community are different trainings, and we also offer mobile crisis program consultation. Thank you so much for your time today, and I'm available for questions during the question and answer section.
Terrific. Kate and Annie, thank you both so very much. These were two very rich and informative presentations. I really commend the work that both of your teams are doing, especially during this time of disruption. And I can imagine, both of you mentioned the wellness aspects of this and the need to take care of the wellness aspects of first responders too. And so I appreciate the leadership both of you are providing to your team. We're not going to have an opportunity to address the questions in the chat box. I do hope that many of you will be able to participate in a discussion group, which will be nothing but a question and answer period. You'll be able to submit questions in the chat box. You'll also be able to unmute your phone to ask questions directly to the presenters. So as a reminder, I think, Julie, were you going to put the link into the chat box for folks at this point? We're going to ask you to terminate this session. Go to the link in your calendars that announced this webinar and click on the Adobe Connect link and then call in on your phones with the participant number, and then you'll be able to participate fully. So there's the link. I see that Julie's done that. To our presenters, thank you again. Please disconnect from this webinar and re-enter through Adobe Connect. Thank you very much.